Well, the short answer is the case. I don't think we can make much progress until we know what we're looking at. I think everybody knows clinically when you see a patient with post-thrombotic syndrome what we're talking about. Clinically, we think of post-thrombotic syndrome as some combination of pain, swelling, skin changes, and ulceration after a deep venous thrombosis. The problem is that we don't really have any good mechanisms to study post-thrombotic syndrome. There's at least 3 instruments that have been proposed in the literature, and particularly the medical doctors have jumped on board of this Villalta instrument, which is the holy grail in a lot of papers of what constitutes post-thrombotic syndrome. And this is the real problem in studying post-thrombotic syndrome, is none of these instruments are very good. The Ginsburg instrument's the easiest, looks only at pain and swelling, but it's completely insensitive to mild post-thrombotic syndrome. The Villalta syndrome, which is the huge one in the medical literature, is just the opposite. It's overly sensitive to mild post-thrombotic syndrome. You identify a lot of patients who probably don't have clinically significant post-thrombotic syndrome, and it's also troubled by the fact that there's plenty combination of both patient-reported symptoms and clinician-observed signs, which I don't think anybody in the world would ever develop an instrument that included both. And finally, the Venous Clinical Severity Scale, which suffers with some problem, particularly in the pain aspects of it, from inter-observer variability. And the result is you get a huge variability in what the incidence of post-thrombotic syndrome is in the literature. If you look at the stocking trials, the incidence is as low as 5% if you use the Ginsburg scale, but as high as 71% if you use the Villalta scale. And I think all you can conclude is these aren't measuring the same thing. None of these instruments use standard psychometric validation, and none of them are patient-reported outcomes. None include quality of life. And this is the real problem with all the research in this area, is we really don't know what we're talking about. That being said, probably the best data comes from Prandoni, who had an 8-year follow-up of 355 patients with a first symptomatic deep venous thrombosis. Again, the primary outcome is the Villalta score, which again over-identifies post-thrombotic syndrome. And the incidence of all post-thrombotic syndrome at 5 years was 28%, and the severe post-thrombotic syndrome 5%. Also, if we look at the Villalta score, we get some idea of what the risk factors are, and I think we have to understand the risk factors before we understand how to prevent it. This is Susan Kahn's study, a somewhat higher incidence of post-thrombotic syndrome of about 40%, only 3% of which was severe. But the predictors of post-thrombotic syndrome, the most important ones were iliofemoral deep venous thrombosis, a previous ipsilateral DVT, obesity, age, and female gender. So how do we prevent it? And I think there are 3 things which are still we can do to prevent post-thrombotic syndrome, some of which I think are more in question now than they were 5 years ago. And essentially those, probably the most important one, is ensuring an adequate intensity and duration of anticoagulation. Thrombolytic therapy, I think, has an evolving role in iliofemoral deep venous thrombosis. Femoral popliteal DVT remains to be seen. My personal opinion is this is going to turn out to be negative, in that the risk won't justify the benefits in femoral popliteal DVT, and a question of the role of compression stockings. Well, as far as preventing recurrent deep venous thrombosis, I think our current understanding is that deep venous thrombosis really isn't a disease of the legs at all. It's a chronic disease of anticoagulation that's manifest in the legs. This is another Prandoni paper, a very large series looking at over 1,600 patients. Over a median follow-up of 4 years, 23% of them developed recurrent deep venous thrombosis. What's surprising about this study is at 10 years, not only is the incidence of recurrent thrombosis extremely high in idiopathic venous thromboembolism of about 50%, it's also surprisingly high in those who are presumed to have a provoked DVT. About 1 out of 4, even patients with a provoked DVT, will have a recurrent venous thrombosis. And I think in conclusion, we clearly see this as a disease of coagulation, not a leg disease. And this manifests itself in clearly recurrent DVT is probably the most powerful risk factor for the development of post-thrombotic syndrome. This is the same data set that Prandoni used to define the incidence of post-thrombotic syndrome. Not surprisingly, the incidence is about the same at about 30%. But ipsilateral recurrent deep venous thrombosis is associated with a 2-fold increased risk of post-thrombotic syndrome, which was much more important than either thrombus location, although this group didn't look at iliofemoral deep venous thrombosis, or the extent of thrombus. Ipsilateral recurrent deep venous thrombosis was really the important factor. And adequate intensity and duration of anticoagulation is probably the most important thing we can do in preventing post-thrombotic syndrome. And I think this is going to get better with time. We have no data on the new novel oral anticoagulants, but there is some data, particularly regarding low molecular weight heparin, that better quality anticoagulation does reduce the incidence of post-thrombotic syndrome. This is a Spanish study in which patients were randomized into the 3 months of enoxaparin, which clearly is better at consistently blocking coagulation than is the variability associated with warfarin. And among those patients who were randomized to enoxaparin, they had more recanalization at 30 days, about a 50% reduction in recurrence at 5 years. And although the numbers were too small for this difference to be statistically significant, there's clearly a trend towards reduced post-thrombotic syndrome with improved anticoagulation. And I think we're probably 5 to 10 years from showing this with the new oral anticoagulants, but I would expect that their more consistent control of coagulation probably will also result in a reduced risk of post-thrombotic syndrome, similar to enoxaparin. Well, how about thrombolysis? I think for iliofemoral deep venous thrombosis, the data isn't strong, but it certainly is suggestive of a role. This is a systematic review that was commissioned by the American Venous Forum and the SBS, looking at 4 studies. These were all comparative studies, so they included both those treated with anticoagulation and thrombolysis. And in these 4 studies, there's about an 80% reduction in the risk of post-thrombotic syndrome, 80% reduction in the risk of venous reflux, and 70% reduction in venous obstruction. This has now been somewhat validated by a very poorly done randomized trial. I think everyone's familiar with the CABIC trial, which has multiple problems. Probably the most important one was it didn't include just iliofemoral deep venous thrombosis, but included DVT above the mid-thigh, but they were randomized either to standard coagulation or catheter-directed thrombolysis, not pharmacomechanical, and there was a reduction in post-thrombotic syndrome from 55.6 to 41%. The problem really is this 14.4% risk reduction really isn't a home run, and I don't think this is ever going to be enough to convince our medical colleagues of the value of this, but I think it has a lot of problems that really will await the ATTRACT trial, which I think is a much larger and better done study. Patients are randomized to best medical therapy or pharmacomechanical lysis, and it includes objective quality of life endpoints at the end. And I think this will tell us the role both in iliofemoral, which I think will be positive, femoral popliteal, I'm not so sure. The study is now completed enrollment. It will probably be 2 years before we have data. Finally, what is the role of compression stockings? And this is evolving. This is a very nice meta-analysis done by Stavros about 10 years ago, looking at the 4 randomized trial in the literature. Stockings were associated with a non-significant reduction in recurrent DVT, but about a 50% reduction in the incidence of post-thrombotic syndrome. I think a couple of series have called this into question. This is a very poorly done series done by myself. This is not a good study, but it randomized 69 patients to either compression stockings or no stockings. In contrast to some of the other trials that had a very high incidence of iliofemoral deep venous thrombosis, compliance is what we would expect in our general practice, 80% at 6 months, dropping to 60% at 2 years. Again, we see the same problem with the instrument that we use to assess it. If we looked at the venous clinical severity score, very few people develop post-thrombotic syndrome, only about 20% over 2 years. If we look at the Villalta score, again, the darling of the medical community, about 80% of patients will develop post-thrombotic syndrome over 2 years. This is the same patient population. Who knows how many of them really develop post-thrombotic syndrome, but there's no difference between groups. This has been confirmed in a larger trial, the SOX trial, which has been very controversial. Much larger trial, 806 patients randomized to stockings or placebo. We see the same exact thing as you saw in our trial. If you use the Ginsburg criteria, very low incidence of post-thrombotic syndrome, 14% at long-term follow-up. If you look at the Villalta score, very high in incidence of post-thrombotic syndrome. Again, the same patient population, different numbers, but no difference between the 2 groups, and compliance exactly what we saw in our trial. This has been criticized largely because of the compliance data, but I would submit to you that this is a real-world trial. This is what you and I see in our practice every day, that not 100% of patients wear stockings. And I think it comes down to it that these patients are going to self-select themselves. Those who need stockings will probably continue to wear them. Those that aren't getting any benefit from them probably won't wear them. And that's hard to study in a clinical trial like this. I personally believe, despite this data, there probably is some benefit, but it's very hard to show in a real randomized clinical trial. So in conclusion, I think the most important thing about preventing the post-thrombotic syndrome is preventing recurrent thrombosis with adequate coagulation. I think all of our studies are flawed by the use of this Villalta scale in particular. This is just a bad instrument. I don't know how it ever got started in the literature. As far as preventative measures go, I think there clearly is a role for adequate intensity and duration of anticoagulation, a 1B recommendation. Thrombolytic therapy for ileothermal DVT is not for everyone, therefore it's a 2 recommendation, and B, based upon 1 randomized clinical trial. Compression stockings, I think, is a 2C now, because 2C, the C designation implies that it's likely to change with further research, but I don't think it's as secure as it once was. Thanks very much.